how can I do this? Yeah, I did. Doesn't work. Okay. All right. The conventional CABG versus OPCAB is still the controversial, and this is one of the paper from the John Pascal's group, and they published in the Annals of Thoracic Surgery in 2009. And the purpose of their study was to evaluate which patient subgroup benefit most from open CABG rather than the conventional CABG using the STS national database. This slide, this figure shows the progression curve comparison of observed mortality rate for OPCAB and the conventional CABG across all levels of the predicted risk of mortality. As you see, the benefit of open CABG is most significant for patients with a predicted risk of mortality values above 0.03, which means 3%. So, in their conclusion, OPCAB is associated with lower operative mortality than conventional CABG for higher risk patients. This mortality benefit increases with increasing predicted risk of mortality. So sounds like OPCAB is very beneficial for the high-risk patient. However, as you know, there are many randomized controlled trials to compare the open CABG and the conventional CABG. And then so far, the OPCAB is quite against to the, from these studies. Main reasons are a couple of things. The OPCAB has less compared to revascularization and less graft patency compared to the conventional CABG. I think this is more technical things, why the less compared to revascularization and the less graft patency. However, as you see, annual trends of OPCAB in Japan is quite stable and about 60% for those 20 years compared to the much more compared to the Western countries. I'm not gonna talk about why in Japan is so much the rate of the OPCAB is high, but we are not compromising any. So the question is OPCAB difficult to perform? Of course, yes. It's a really technically demanding thing. The reason why is the heart is beating. That's very simple. So the key to success, the OPCAB, to perform 100%, there are two aspects, technical aspect and the patient selection. I'm going to talk about the patient technical aspect first. The key issue for the technical aspect is the stabilization of the target vessel and how to expose the heart. The first, stabilization. There are several devices to stabilize the target vessel, the coronaries. I use the Medtronic devices, but doesn't matter which kind of the device you use. And the exposure. This is very, very important, especially to expose the inferior wall or posterior wall, lateral wall, without compromising the hemodynamics. This is the most difficult thing and the most important thing to perform the open CABG. So exposure of the heart during the OPCAB. There are two ways to expose the heart. One is using the deep pericardial sutures, which is so-called the Lima suture technique. Another one is apical suction device, such as a Medtronic starfish device. So there are some advantages and disadvantages. Using the Lima suture, I think, this is my personal opinion, but advantage is it works with a large heart. But the disadvantage is when you perform the sequential bypass, it's not convenient to move around. On the other hand, the apical suction device, such as the starfish, easier to change the position during the inferior anastomosis or the posterolateral, especially in case of the sequential bypasses. But it's not good for the bigger heart. So this flow chart shows how to select the way of the exposure technique. This is my personal the way. In the case of the big heart or the thick fat around the LV apex or the anterior wall infarction. So in case of those situations, I tend to use a Lima suture because if the thick fat around the LV apex, it's a high risk to have the laceration using the suction device. And in case of the laceration, you may have a very difficult to fix it. I mean, you can fix it. It's not arterial bleeding, but sometimes not so easy to fix it. And that's my way how to select. Of course, you can have the mixture. And then also, deep pericardial suture technique. I tend to use the volume loading rather than the alpha stimulant. But using the suction device, if you load the volume too much, the heart gets big, and it's difficult to lift up the heart. So I tend to use the alpha stimulant. So the patient selection. This is another key issue, how to success the 100% off pump. When not to the OPCAB. This is I'm going to show you this is my personal experience of the CABG. This including the not only the off-pump CABG, but also the on-pump beating, on-pump CABG. So about 13 years, I've operated on the more than 1,700 cases. 70% cases are triple vessel disease. In other words, 30% are the single vessel and the double vessel. The risk factors for the patients, half of them are diabetic, and about 10% is on hemodialysis. So the total isolated CABG number is 1,708, and then off-pump CABG was 1,663 cases, on-pump CABG was 45 cases, which means the off-pump rate was 97.4%, which is not 100%, but a pretty good number, I think. And then in 45, aim to perform OPCAB was 1,675 cases, and the conversion to on-pump was 12 cases, which means a conversion rate of 0.7%. OPCAB accomplishment rate was 99.3%. This number of the 1,663 cases off-pump CABG, distal anastomosis 3.2, including the double vessel disease and the single vessel disease. Bilateral usage, I tend to use the more and more arterial graft. Almost 50%, I use a bilateral mammary. And all arterial grafting was just 50%. Complete revascularization rate was 99.2%. So I'm not compromising. The result of the major complication, hospital death was 0.4%, which is pretty good, I think. And CVA, cerebrovascular accident, was 0.4%. So the number of average grafted vessel was 3.2%. Again, this is including the single vessel disease and the double vessel disease. The maximum number of the grafting was 8. And we, in Japan, they tend to do the post-op angio during the admission. And we performed 72% of all cases, the post-op angio. And excluding the criteria was the chronic the renal failure patient, and also the patient who refused the post-op angiogram. The total patency rate was 98.7%. Of course, this is the acute phase, okay? So I'm going to show you what kind of cases we use a on-pump. In 45 cases, I use a cardiopulmonary bypass machine. The conversion from off-pump was 12 cases, and elective on-pump cases 33 cases. And this group, the elective CABG, 33 cases. On-pump beating was performed 25 cases, and the conventional CABG with cardiac arrest was 8 cases. Recent cases are almost the on-pump beating. We're not gonna stop the heart. So I'm gonna focus on the conversion cases. There are 12 cases. All of them were triple vessel disease. And the ejection fraction less than 30% was 1/3. Bilateral mammary usage was half of them. So complete revascularization was 100%. All of them, we use the on-pump beating technique. And then those all cases are all emergent conversion, not elective conversion. So this is a paper from the European Journal of Cardiothoracic Surgery, published in, I can't say it, like 4 or 5 years ago. The purpose of their study was to evaluate the impact of conversion after OPCAB from coronary trial experience. As you see, the impact of conversion on the composite outcome at 1 year. It's a marked difference, conversion group and then other groups. So they concluded that the emergent conversion is associated with worse outcomes compared with the elective conversion or no conversion. This is my result of the conversion cases. Actually, the result is different from their study. No hospital deaths, no cerebrovascular accident. So for me, the conversion, even the emergent conversion, is not so high risk. Now, I'm going to show you the comparison between the OPCAB cases and the on-pump. This is the elective on-pump cases. The number is quite different, but there's some difference between two groups, especially here. Acute myocardial infarction is more, which is more for the on-pump cases, which is statistically significant. And the redo CABG is more in the on-pump cases. So, in conclusion, the personal experience, contraindications for OPCAB might be acute coronary syndrome and the certain groups of the redo CABG cases. Except for these groups of patients, even adding conversion to on-pump cases, OPCAB can be performed with confidence. So, in summarize my today's talk, OPCAB can be performed over 97% of isolated CABG cases without any compromises, as I showed from this slide. However, in some cases, OPCAB, such as acute coronary syndrome or redo cases, is not suitable to be performed. So adequate patient selection is key to achieve optimal result. So some surgeons say, I can do 100% off-pump. Of course, you can do it, but some cases, you can't do it, but you can perform the OPCAB close to 100%. Since high-risk patients must be the ideal target to receive benefit from off-pump CABG, to save this group of patients, it is important to be familiar with this technique. In other words, if you do like occasional OPCAB surgeon, you can't save this group of the patient. Thank you very much for your attention.
Thank you, Professor Ninami. And we don't have the third and fourth speaker today, so we have plenty time to discuss and talk about the benefit of off-pump. I think your experience is very impressive, 1,700 patient off-pump. But the focus of debate now is not the short term. The focus is actually the long-term outcome. And I think a majority of people agree, short-term wise, off-pumps carry some advantage. But all the randomized trial, evidence available, comparing on-pump and off-pump, long-term outcome of pump showed the worst result. So what's your opinion?
Yeah, thank you very much. That's a good point. But I haven't have the enough data to show you the long-term data. But the important thing is, as I mentioned, why the OPCAB is not good for the long term is less compared to revascularization, less compared to revascularization rate, and also less graft patency. But according to my data, as I shown you, the complete revascularization rate is almost 100%, and graft patent is over 98%. So it should be good for the long term. And I tend to use more and more arterial graft, which is also good for the long-term outcomes. But I haven't have enough data yet. I'm start analyzing those data. So I will show you maybe next time, all right?
Please.
One question, please. If you think that this technique is good, especially in Asian country, we do a lot of off-pump. But in European and in North America, they do less 10%. Do you think that if the patients know this, and if you think that your technique is so good, do you think that the European or American peoples get the inferior techniques? Do you think that?
I'm not saying they're inferior, but the important message from my today's talk is the off pump is not for the beginners. Okay, the operation off pump is difficult to perform, especially using the more and more arterial graft. So people start saying that the CABG is not the general cardiac surgery. Certain the cases of CABG is a kind of subspecialty. So only the experienced surgeon should perform. So like a octogenarian, like a low ejection fraction patient, those are a high-risk patient. It should be performed by the op pump because there is some evidence to show the OPCAB is better. But to perform these cases, you can't be the occasional OPCAB surgeon because those cases are more difficult than the not high-risk patients. So that's why I'm insisting to perform OPCAB you should perform like a 80%, 90% op pump. So the concept is quite different. Like my country, the ratio of the CABG is only 30% of all the cases. But in European country, for instance, like a UK, they perform the CABG like still 70%. So they say the CABG is a general cardiac surgery. But in Japan, the CABG is not, it's like the valve surgery, aortic surgery, and the CABG is also the kind of subspecialty. So only the selected doctors can perform. So that's a major difference. So I can't push them to perform the op-pump CABG I'm talking about the Western countries. So the situation is quite different. That's a major reason, I think.
Can I have one more question? Like you said that in order to do a good off-pump, you have to have a lot of supporting, like instrument, money, or like a transit-time measurement, which is very high cost to bring you to the good result of off-pump. What about developing country like us or a third world country who wants to do the off-pump? If they don't have this supporting instrument, what should they do?
What kind of instrument you are talking about?
Talking about stabilizers expensive.
Stabilizers?
Transit time for measurement is expensive.
But the stabilizer ones, actually the recent the practice, I don't use the starfish. I use the 95% of my cases, I use only Lima stitches, which is quite cheap, only 2 heavy silk sutures. And the octopus device is, I think, that's cheaper than the permanent bypass circuit. So I think economically, the OPCAB is cheaper, and then the less bleeding. So that means less transfusion and the less staying the period in the intensive care unit and the shorten the hospital stay. So those things are adding, and then the economical aspect, that's much cheaper compared to the conventional the CABG, I think. So I don't think this the technique is cost more than the conventional CABG.
I think one of the important things is the graft validation after you do off-pump surgery. I mean, it is very expensive. In order to show up that off-pump technique can have a good result early and long-term result, graft validation, like intraoperative field, is very important. I mean, if we start this program, I mean, without graft validation, is it fair for the patients to do, or is the best way we can do? What do you think for the patients?
I'm sorry, I can't catch
I
up.
mean, suppose like in Thailand, we don't have money to buy the machine to do the graft validation. So you do on pump, you know, sometimes you can push the saline, you know it's not occluded one. But off pump, you cannot make sure that your graft is validated in a good way. Is there any way to do it?
Yeah, but that is not only the to evaluate the OPCAB cases, but also that's good. There is the guidelines show the class 2B recommendation to use the device to measure the post-op graft flow. So, but yeah. But I agree that you should have that kind of the evaluation machine after the off-pump CABG. That's no question for the beginning of this OPCAB technique. But there's some kind of way to evaluate. I'm not sure. It's because in Japan, it's over 90% of the centers use this machine to evaluate.
Dr. Moon, please.
Hi, my name is Byung Moon. I'm from Toronto. Thank you for your talk, and I actually enjoyed the discussion quite well too. One of the things that I would like you to make a comment is, for high volume surgeons, it doesn't matter whether you do off pump or on pump. I do mine mostly, I mean, I was doing off pump, but I've gone back to on pump for many years for basically the long-term result that I'm looking for. I think a couple of things. One, the reason that we operate on patients, at least in my point of view, is that we want to make sure patient is well at the end of 10, 20, 30 years. And I want to do a good job first time. So on that note, I think everybody agrees. We want to make sure the graft patency is good, mortality is good, comorbidities are also pretty good. The issue is, as I would like to make a comment, is that for high volume surgeons like you, it doesn't matter whether you do off pump or on pump. You know what, personally, I find that when I do off pump, those vessels look much smaller than when I do an on pump. So my numbers actually change. And I noticed that, and I didn't like it, so I went back to on pump. For surgeons here with a low volume hospitals, would you consider them to be a specialized and do off pump? Or would you be comfortable to say, let's do a good job first time and learn the technique with on pump and be comfortable? You know, the pump, we've actually gone off pump in order to compete with cardiologists, PCIs, a long time ago. But the advancement of cardiopulmonary bypass, the peri-anesthesia technology and all that has immensely improved to a point where patients do really well regardless whether you're on pump or off pump. Don't get me wrong, because there are certain patients we shouldn't touch on pump. But majority of the patients we do. My practice, used to do about 360 a year for CABG alone. I still do the valves. But beside that point, the advancement of pump has gone so well that I feel very comfortable telling my patients, you know what, the risk of pump is not there as much. Could you make a comment for the audience who's going to go back home doing low volume cases? whether you feel comfortable for them to say doing an off-pump. I mean, on-pump is a great way of doing it. I think on-pump is also a good way of actually teaching junior surgeons how to do coronary artery bypass grafting. Thank you.
Thank you very much for your question and your comment. I completely agree that I do also the valve surgery and the aortic surgery, and of course I use the cardiopulmonary bypass machine, and that's advancement of the cardiopulmonary bypass machine is quite a lot, and it's very safe to use it. But I really don't know why in Japan that we use the OPCAB technique so much. As I showing you in my slide, 60% of that's not my the small the community the rate. That's the whole Japan. So, and my country we have 580 centers to perform open heart surgery, and we do 60,000 cases in a year, which means only 100 cases a year that one of the centers perform. So each centers, average centers, the number of the open heart surgery, including open CABG, is quite low. However, still they perform the open CABG. So I don't think that only the high volume center surgeon can perform this procedure. I do this. I'm one of the high volume the OPCAB surgeon, but even the youngers, they perform op-pump safely without compromises. So one of the talk about the training, we do have the kind of the simulator to put the stitches. That's one thing we can learn. And some surgeons, the younger surgeons like 30s, 40s, some of the surgeons started the CABG without the cardiopulmonary bypass from the first case. So those surgeons are increasing in my country, and that's quite different from the Western countries. And personally, I've been doing this the practice for more than 20 years. I mean, talking about off-pump. For me, it's difficult to change to the on-pump technique because much more simple compared to the on-pump. And this is not scientific, but the Asians in general tends to bleed. So giving the less heparin, ACT level of 250 to 300, much easier to stop bleeding after administration the protamine. So that's, and we tend to use lots of the arterial graft. Sometimes we have to do the combined operation, CABG, total arterial graft, and AVR. In that case, it's difficult to stop bleeding because we have to control the ACT like over 500. So comparing these things, the OPCAB is really beneficial. That's we think. That's why our society in Japan, the people tend to use the op-pump technique. So there are many reasons why we still keep doing this technique. There are some advantage, and we feel less disadvantage. That's a reason, I think.
Maybe the last question. Yeah.
Okay.
Sorry, Dr. Moon, you want to?
No, I just, sorry. Then can you make a comment that the reports that's coming out now saying that the on-pump patients' long-term results, the graft patency, including the number of grafts that we put on patients, are better with on-pump. Can you make that comment?
Can I answer this one? My name is Jahangir from Bangladesh. I mean, my experience with doing off-pump, the number of graft in CABG has increased over the time if you compare with the on-pump. The reason probably is the aggressiveness of the invasive cardiologist. Now that cases that we get in our country always are so diseased and so advanced and all. So you graft more vessels in beating heart is possible than you put on a bypass or give cardioplegia. Secondly, I mean, in this era, where you have diseases so advanced and also the left ventricular function is low, we can better handle with the low ejection fraction cases with off-pump cases than in on-pump. So considering these two cases, I'm doing off-pump cases for last 20 years. And then again, similarly like you, that all my trainees, more than 10 centers for the chief cardiac surgeon, they have only learned beating heart. Not that I have gone through, traditional on-pump. I don't disagree. There are cases. Suppose with high uninterrupted support, the pressures are low, you convert it. But this scenario, we are more comfortable doing beating heart, especially also the lie of the conduit is so comfortable. It lies so good in comparison on on-pump. Thank you.
And thank you very much for your comment. And answering your question, there is not so many countries to perform the post-op angio during the admission. And in my center, we perform like a 70% post-op angio, using mostly not the CT, just the usual angiogram, and to show the patency because of the lots of reasons. Still, we are doing, even the patient doesn't have any symptoms. And I show the total of the patency rate was more than 98%. So, of course, this is an acute phase. Some graft may fail, but at least the acute phase, we confirm the graft patency. Of course, we do the intraoperative graft assessment. So, if the acute phase graft patency we confirm, of course, some of the graft may fail, but still, we show the good graft patency even using the off-pump technique, and we need to analyze the long-term data, but the same or a little bit more compared to revascularization compared to the on-pump cases, and the good graft patency. I don't think there's no compromise, and I don't think the OPCAB is worse than the conventional CABG, that I believe. But I haven't seen I can't show you the data yet, but I will in the future.
Thank you, Professor Ninami. 2 days later in this meeting, I'm asked to give another talk on the same topic, on-pump, off-pump. I'm going to review the very latest updated literature, so hopefully I can provide some more evidence. Thank you very much. Now it's my turn. Can I have the slides? Yeah. I must thank Tavisa and the organizing committee give me this title, FFR, positive and moderate coronary stenosis, leave alone or CABG. When I received this topic, I was surprised. And my gut feeling, it's very simple, do it. But I searched the literature. Actually, I learned a lot. So yeah, I don't have anything for disclosure. So I'm going to talk about FFR-guided CABG, whether this is a step forward. And the second point is moderate coronary stenosis, whether we should graft or not graft. After discussing these 2 points, I think the third question is actually very simple, straightforward. FFR, positive and moderate coronary stenosis, whether we should leave alone or do CABG. The first question, FFR-guided CABG, whether this is a step forward. Actually, before I learned the literature, I saw that answer is very simple. Yes, FFR-guided CABG is a step forward, but the evidence shows somehow different direction. We learned from FFR-guided PCI, which is actually much superior than angiography-guided PCI. And this is a landmark study called FAME study, the fractional flow reserve versus angiography for a multi-vessel evaluation study published in New England Journal, 2009. And afterwards, there were a lot of similar study, all proven FFR-guided PCI is better than angiography-guided PCI. But somehow very interesting, the superiority is because safe deferral of lesions that were angiography showed stenotic but did not actually result in lesion-specific ischemia. In a simple word, FFR-guided PCI, they do less stenting than angiography-guided PCI. So less is more, less is safer. This is the lesson learned from PCI. But evidence in the CABG field actually is much lesser than PCI. This is a study actually got a 6-year follow-up. FFR-guided CABG compare with angiography-guided CABG. This study was conducted in 2006 to 2010, single institution, European Center, retrospective study. FFR-guided group, almost 200 patients. So the criteria is at least one graft was according to FFR assessment. In fact, the two groups are not very comparable in the first place. The angiography-guided group, more than 400 patients. All the CABG planning was based on the angiogram. But FFR-guided group patients were younger, more male patient, less diabetic. At least one graft was based on the FFR guidance. So roughly see the result. Seems it's all in favor of FFR-guided treatment. Whether you see the overall patient population or you see the propensity-matched group, FFR-guided with angiography-guided. Talk about the MACE, it's less in the FFR. Talk about death, myocardial infarction, seems all in favor of FFR guidance. Look at the details. When you put death and MR together, there was a statistical significant difference in favor of FFR guidance. However, when you look at the deaths specifically, there was no statistical difference. Number seems still in favor of FFR guidance, but there was no statistical significance. When you look at myocardial infarction individual, again, the number seems in favor of FFR guidance, but there was no statistical significance. MACE, again, the same. No statistical significant difference between the groups. Target vessel revascularization, there was no difference at all. Very interesting, graft occlusion is in favor of FFR guidance, statistically significant. However, look at the number. FFR-guided group, only 35.9% received the follow-up angiogram. Angiography-guided, even less, 23.3% received angiogram. So this is not completely representative data. However, this is in favor of FFR-guided CABG. The authors actually concluded FFR-guided CABG is associated with fewer graft anastomosis, higher graft patency rate, as well as lower rate of overall death and MI, out to 6 years as compared with angiography-guided CABG. This is a retrospective single institution study. There are so far 3 randomized trials on this topic. I'm going to talk about the 2 of them The first one, published in JACC 2018, it's called FARGO, Fractional Flow Reserve versus Angiography Randomization for Graft Optimization. The FARGO study is the first randomized trial comparing FFR-guided CABG versus angiography-guided CABG. The heart team actually made the plan for CABG for all patients based on angiogram. And there are total 100 patients get randomization. In fact, finally, less than 100 patients eventually underwent the whole study. The FFR-guided group, the surgeon was informed FFR result before the operation. So he can revise the CABG plan based on the FFR result. The angiograph-guided group, the surgeon completely blinded with the FFR result. So based on the angiogram, they do the CABG. The primary endpoint is graft failure rate after 6 months. All the patients receive follow-up angiogram. Very interesting. FFR-guided group got less graft because based on the FFR result, some graft was considered not necessary by the surgeon. So although the planning was 3.2 graft for each patient, eventually FFR-guided group mean graft is 2.5. So at least 1 graft less than originally planned than the other control group. The graft failure rate, somehow exactly the same. FFR-guided group, 6 months later, about 16% graft failure or occlusion, and more or less the same, equal to an angiography-guided group. This is a very interesting point. 6 months later, when they repeat FFR measurement, there was a significantly reduction of a FFR reading. The same lesion, they do the FFR again. This time, the FFR reading is significantly less than before. So only 6 months in between. Seems those grafts, you should do it in the first place rather than leave it alone. The authors concluded, compared with conventional angiographic assessment, measurement of FFR to guide surgical revascularization does not improve short-term graft patency or clinic outcome. So of course, larger randomized study with longer follow-up are necessary to determine whether FFR-guided or angiographically guided revascularization differentially influence rates of graft failure or the need for later revascularization. That was the first randomized trial, and this is the second one. It's called the IMPACT. Impact of preoperative fractional flow reserve on arterial bypass graft anastomotic function. This trial was performed in one of the Canadian center, one of the European center, 2 centers, and all randomized. Very specific point is all patients receive total arterial graft. There was no vein graft. So this is a very unique study design. Total only 67 patients, but there were almost 200 coronary lesions and all arterial graft. The conclusion is actually preoperative FFR was significantly associated with 6 months anastomotic function for all conduit and for all target. And FFR value less or equal to 0.78 was associated with anastomotic occlusion rate of 3%, which is actually quite good. Compared with FARGO, this time the graft is so-called complete revascularization. FFR-guided group, they do the same amount of graft. And also, all graft was arterial graft. There was no vein in this study. So the take-home message is, if you do total arterial grafting, preoperative FFR cutoff of 0.78 actually is beneficial to guide your anastomosis. The authors concluded a highly significant association between preoperative FFR and anastomotic arterial graft function at 6 months in CABG patients. Arterial grafts to target vessels with FFR less than 0.78 had extremely high patency rate at 6 months. And I agree with Professor Ninami. Acute phase angiogram doesn't necessarily reflect 6 months, 18 months, 2 years, or even longer patency rate. So 6 months angiogram is more meaningful than immediate post-op. And this result suggests that FFR may play an important role in preoperative planning of CABG procedure, should be utilized whenever possible, particularly for surgeons utilizing multiple arterial conduits. This is a positive finding, but this is very specific, addressing arterial graft. And there was the third randomized trial called the Grafty. Grafty, 50% of the anastomosis or the graft were arterial, so still 50% using the vein graft. It's more than Fargo, but still less than impact. And Grafty, the result is more or less the same as Fargo, negative. FFR doesn't improve postoperative graft failure. So this is the most updated expert consent. You see the author included Dr. David Target. FFR for CABG, not ready for primary time. And this is a very complex issue. I don't think this conclusion will be forever. But so far, FFR-guided CABG, you do less graft. And if you do vein, doesn't give you any advantage. So that's the first point. Whether FFR for CABG is a step forward, so far, not yet. The second point, moderate coronary stenosis, to graft or not to graft. When I was resident, my chief told me, if it's left main less than 50% and the other graft less than 70%, you can ignore it. You don't do grafting. Because if you graft, there will be significant competitive flow. Your graft may have a high chance to occlude. Okay, that was my lesson learned when I was resident. What's the most updated evidence? We don't have randomized, actually, evidence. We have this interesting paper from Cleveland Clinic. This is a very recent publication, 2016. Does grafting coronary artery with only moderate stenosis affect long-term mortality? Moderate means the stenosis between 50% to 69%, less than 70% stenosis. The message from Cleveland Clinic, grafting moderately stenotic coronary arteries is not harmful. Internal thoracic artery grafting of such arteries is associated with lower late mortality. This is somehow against or different with our originally old school teaching. Moderate stenosis, 50 to 69% stenotic based on angiogram. It's a very long-term retrospective analysis. Patients between 1972 to 2011 in Cleveland Clinic. They grafted moderate stenosis in 60,598 patients. In the meantime, almost 2,000 patients, they didn't do graft. So they compare these two groups for 30-year follow-up. This is a very long follow-up study. Overall population, when you look at the survival, do it or not do it, seems the survival is more or less the same. There was no difference. However, when you look what conduit you use, there were significant difference. If you use internal thoracic artery, the mammary artery, the survival is much better, even for those moderate stenotic lesions. If you use vein, it's the same compared with you don't do it. So the vein doesn't give you any advantage. Very interesting study. When you do grafting for non-LAD territory, which is the second important stenotic artery, and you use mammary artery to graft the second most important, usually circumflex artery or diagonal artery. Non-LAD, you use mammary, significant survival benefit over 30 years. When you do vein, it's the same as you don't do it. But you do arterial graft, significant survival advantage. Cleveland Clinic surgeons concluded internal thoracic artery grafting of coronary artery with angiographically moderate stenosis is associated with lower long-term mortality. Therefore, after placing the first ITA to the left anterior descending coronary artery, the second ITA should be used to graft the next most important coronary artery, even if it is only moderately stenotic. Well, the third question, FFR positive and moderate coronary stenosis, leave alone or CABG, based on impact result, based on Cleveland Clinic observation, I think we don't need to discuss this. Just do it. Leaving nothing behind. That's the surgeon's principle. However, FFR positive, the definition is less than 0.78. This is we learned from impact study. And we learned from both study, do an arterial graft is important. If you do a vein, probably doesn't matter. Thank you very much. We still got something like 30 minutes to kill, so any question is welcome. Yeah, Professor Asai.
Professor Sun, fantastic lectures.
Thank you.
And this is the most interesting topic for those who doing arterial graft and CABG. I personally learned that FFR is greatly influenced by the collateral circulation. CABG target patient is more or less severe coronary multivessel disease in these days. So not only that single vessel consideration, there might be some more complex interaction to the collateral circulation, as well as if it is bypassed already, postoperative FFR are naturally changed. So I think this is, I think, a much more complex topic than what I thought initially. And also, the follow-up of these studies you introduced, mostly 6 months, is that correct? And moderately or mildly stenotic artery is actually having a danger of a sudden plaque rupture rather than gradual stenosis. So in terms of preventing myocardial infarction, I think by bypass graft to the moderate or even mild vein or artery, we have still a lot of open questions. In terms of these circumstances, do you have your own message to us? Because I don't have an exact answer for these questions. I think we can spend maybe another 5 minutes with this discussion.
Yeah, I totally agree. I think so far the evidence is very weak. But based on the already available evidence, FFR-guided CABG basically so far result in less grafting. Because some reading,
like a PCI.
It's more than 0.8, so surgeons thought that's not necessary. However, the Fargo give you a very important clue. 6 months later, the reading may change.
Okay.
And you will regret the first time you didn't do it. So that's the first lesson learned. Second lesson learned, FFR-guided CABG probably more meaningful for arterial graft compared with vein graft. And this is the impact study gives the evidence. Basically, if you want to do total arterial grafting, probably FFR guidance is meaningful. And the question they asked me to address is moderate coronary stenosis, which means less than 70%, whether FFR positive is meaningful. And the answer is yes. I think now probably FFR guidance give us stronger support even for the moderate stenotic coronary lesion. You should do it, but better do arterial graft.
Jim Tatulis from Melbourne. I really enjoyed your talk. It was very precise and very instructive. I'd like you perhaps to comment on the RAPCode trial, which was conducted in Melbourne from 2005 to 2015, where we did prospective angiograms over 10 years in the radial artery patency clinical and outcome study. So there, one of the findings was the moderate stenosis on the left side was different to the moderate stenosis on the right side. So on the left side, we found that in the circumflex, a 70% stenosis, this is in the pre-FFR days, but a 70% stenosis was a threshold for improved patency, whereas that was not true on the right. And the second thing we found was that on the right side, the lesion was less likely to progress, but on the left side, it was more likely to progress, like you showed with the increase in FFR. So that was a big difference. And the final thing is that when you use arterial grafts, the lima, or the internal thoracic artery, responds differently to competitive flow than the radial, and then of course the vein graft doesn't so much. So there's so many factors in the mix, but I guess the comment I'd like you to make would be about, do you see the left-sided moderate lesion as being different to the right-sided moderate lesion? And if so, what do you do with the moderate right-sided lesion?
Thank you very much. These are excellent points. And I think these are the very important issue. And based on Cleveland Clinic study, actually, their result is in agreement with your observation, because their second most important target, more than 70% in the left side. Less than 30% RCA, they graft the second most important arterial graft. So I think left side is more important than right side. Right side is higher chance of graft occlusion if it's moderate stenosis, which we have learned from the radial artery study. And also, another important point is lima is different with radial in those moderate stenotic lesion. And Cleveland Clinic does emphasize the second internal thoracic artery to graft on the second most important, mostly circumflex or diagonal. I think these are the very important observations. Thank you very much.
Thank you.
Yes.
Excellent talk, sir. It's an eye-opener. I am Dr. Swapnil Deshpande from India. We are doing a lot of off-pump CABGs. Regarding, just a comment, if there is any moderate lesions on the left side or the right side, do you support, along with FFR, if the FFR level is between 0.78 to 0.85, do you support your patient's CABG decision with a stress thallium or a stress cardiac MRI? Or it is just that it's a moderate lesion, you will go for the graft.
You said the moderate lesion is FFR reading is more than 0.8.
0.78, more than 0.7.
More than 0.78. Based on the impact study result, if you do even arterial graft, the graft failure rate is relatively high.
Yeah.
So the impact investigators suggest 0.78 is a cutoff value. If it's less than 0.78, you should do it. But more than that, still we don't have the evidence to support.
And do you see that if a FFR level on the right side is 0.78 or more, do you go for an independent graft on the right side and go for a total arterial on the left side?
I think for the right side, now the consensus, even we learned from Australian study, the stenotic ratio should be higher. Yeah. Usually we still look at the 90% stenosis and put an arterial graft there. I don't know. What's your opinion?
Yeah, I think in broad terms, yes. What we do with the right side, if it's a young patient, we often will leave a moderate right-sided lesion alone and perhaps stent that later on to avoid using a vein graft, which may fail in a young patient. So that would be one of our attitudes. The other thing I'd like to emphasize to the audience about graft failure rates and moderate stenosis and competitive flow, it's not a binary thing. It's not all the grafts are 97, 100% patent, or they're zero patent. It's not binary. All it means is instead of being a 90% plus patency, it's sort of 70, 75%. So it's not a disaster. It's not zero. So I think people forget that they go, oh, moderate stenosis, I'll graft. If I graft it, the graft will fail. That's not true. It's just that it's a higher failure rate, which might be 20, 25%. So the patency rate is still 75% or thereabouts. It's not zero. So I think that's a very, very important thing which gets overlooked.
Yeah.
But on the right side, as said, in older patients, we would probably use a vein graft if we're not sure. And in younger patients, often we will just leave it because the evidence that we have was that right-sided lesion does not progress as quickly, particularly with good medical therapy, and we'll re-angiogram the patient in the future, and if necessary, stent the right coronary artery.
And another point for the moderate stenotic coronary lesion, you do a graft and graft fail, doesn't really that harmful to the patient compared with PCI if the stenotic in-stent restenosis cause more harm than a failed graft. A failed graft, sometimes the patient doesn't really get immediate myocardial infarction or even ischemia because the competitive flow is still there. So it's different with PCI. Yes, Dr. Moon.
Enjoyed your talk as usual. It was a great presentation. Thank you. Just in our experience, we've been using FFR more for moderate stenosis of LAD rather than other vessels as much. Mainly because if LAD is not bad, then we tend to kind of shine away from the surgical approach at this stage. Your thoughts if the LAD is not that bad and all the other vessels, do you go surgery or do you go PCI?
Well, this is an important question, but to me, as a surgeon, you are there. You do something, for example, for valve or for other operation, and you know LAD got 60% lesion. I think you just do the Lima to LAD. And Lima is more protective, and LAD lesion may progress, and based on the Cleveland Clinic observation, you do a graft, there is no harm. And LAD is so important, you better protect it.
I guess I was trying to say that if the patient is not that symptomatic, what happens to those patients if you don't actually operate? Don't get me wrong, we're all surgeons here, so we do our best work in the operating room. But I just want to know your comments about
I think,
patient.
yeah, I think there is no solid conclusion yet. If it's no symptom and 50% lesion, you leave alone, nobody will really criticize on you, and the cardiologist will be happy in the future to put a stent if it's a single vessel disease. And I think there is no evidence right or wrong. And on the other hand, if you do it, lymphatoid, also nobody can criticize on you. So I think up to you to decide at that moment. You agree? Huh.
I really enjoyed the discussion here, and we have advantage of not many attendants from America at this time. But I agree with Dr. Taturis that I have extensive investigation of another arterial conduit, gastroepiproic. I'm going to talk later. Exactly the same. And there's no difference between radial artery to gastroepiproic in a territory of right coronary area. But as I mentioned, I think that the moderate lesion is not just programmed to be stenosed gradually and occlude. What we don't know in coronary artery disease is a prediction of the next event. So I think we still need to graft, as Cleveland report, to do something. In your practice right now, do you use a vein graft to the moderate stenotic, the right, which is broad territory? I probably do the vein graft if there is no ascending aorta disease by echo. That would be safest, I think, a solution at this point of time with limited information. I think that might be, I think, a tentative solution for multivessel disease.
Well, I think you got your point, but based on the Cleveland Clinic data, less than 70% stenosis, right coronary artery, you put a vein, it's the same. You don't do it.
It's artery?
Oh, yeah. So you don't bring any additional benefit to the patient. Probably it's, you can sleep better that night, but that's all. The patient doesn't really benefit from that vein graft.
Two critical landmark study from, I think one of the David Greener, and the other is Di Mauro from Italy. The right gastroepiproic artery, there is, I think it's 1.0 of, not the percentage, minimal luminal diameter might be a threshold. However, as Dr. Pataturis said, that does not necessarily mean the arterial graft to put, let's say, 1.2 millimeter minimal luminal diameter. It's not 100% occluded. That's the point. We still have a lot of room, need to be elucidated. Thank you.
Thank you. Well, we have 10 minutes early closure, so thank you very much for coming this early morning session. And despite some speaker canceled the trip, but we still got very fruitful discussion. Thank you very much. We add one more talk. Dr. Moon is going to talk about the management of moderate aortic stenosis during coronary bypass graft. Dr. Moon, please.
Good morning. I really know that he doesn't like me. I apologize. I'm basically a pinch hitter as far as this talk is concerned. Now that we only have 10 minutes, I guess I have to talk really fast. My task was to talk about we deal with every day when we do open heart surgery, especially bypass surgery. Basically, the management of moderate aortic stenosis during coronary artery bypass grafting. These patients with moderate aortic stenosis, their symptoms are really not there, and certainly masked by coronary artery disease. And what the current decision-making is, or a better title would be to replace or not to replace. Just a quick thing, with the aging population, the incidental aortic valve disease among patients undergoing so-called CABG is quite common. And it is, while it is widely accepted that the severe aortic stenosis should be managed with concomitant aortic valve replacement at the time of surgery, treatment of moderate aortic stenosis still is a decision-making at the time of surgery. It depends on patients' conditions, it depends on what the surgeons feel like that day, et cetera, but we want to make sure that we do what's the best for a patient. And to a certain extent, it still becomes a bit of a decision-making. The controversy is mounted because the fact that there's a difficulty in assessing the rate of progression of aortic stenosis in some of these patients, and whether the patient will literally outlive the natural progression of aortic disease, especially because we're now dealing with much more elderly patients at this stage. The concomitant aortic valve replacement certainly avoids the risk of what we call long-term reoperation for progressive native aortic valve stenosis. However, extra procedure certainly may expose to additional perioperative risks, including long-term prosthesis-related complications. The fact that we may not have explained to the patient what we may do because we only find this out during a transesophageal echocardiogram once the patient goes to sleep. I believe it is important for surgeons to certainly explain to patients before surgery all the things that may happen at the time. Conversely, the performing only coronary artery bypass grafting may also expose these patients to higher risk of late reoperation for aortic valve replacement. There are a lot of times comments saying the added or redo operation for these aortic valve replacement may not increase the risk at the time of actual redo operation, but I think it's a cumulative morbidity and mortality, so these are the things that we need to consider. And certainly from surgical point of view, technical point of view, it is certainly a challenge, especially if you have live grafts. And I know with the advancement of other technology, this may not be as of a problem. And you have to remember that patients are going to be 5, 10 years older by the time that you do reoperation. We all know this graph from 1960s. The reason that we recommend surgery in patients with a severe aortic stenosis, certainly because of the relative risk, comparing the relative risk of surgery and medical therapy to the natural course. Patients with severe aortic stenosis, as you know, once they start becoming symptomatic, their mortality rate suddenly increases. And what we want to do at the time of surgery as a surgeons is to revert that graph back. The operative mortality for surgical aortic valve replacement in any case varies widely. It depends on patients' clinical conditions and comorbidities, whether they're an elective case or whether they're an emergency case. And obviously depends not just on surgeons, but the surgical centers where they have other resources. We talk about this as much these days, but the insertion of prosthetic heart valve in any patient is certainly associated with other appreciable morbidity, including the dysfunction of its valve, paravalvular leaks, thrombus formation, thromboembolism, etc., endocarditis, and problems associated with anticoagulation in some of these patients. And going through the literatures, there are significant comorbidities or complications that may occur up to about 3% per year per patient undergoing aortic valve replacement. And we talk about death directly due to the valves in about 1% per patient per year. The recommendation for surgical aortic valve replacement at the time of CABG largely is based on comparison, as I said, with a natural history of patient to outcome after surgical aortic valve replacement. The guideline still stands of 2014, but revised at 2017 AHA-ACC guidelines still recommends these with the patient's severe aortic stenosis to undergo while undergoing other cardiac surgery. But the main question is aortic valve replacement on the guideline that aortic valve replacement is suggested for patients with moderate aortic stenosis who are undergoing other cardiac surgery at the time. Mild aortic stenosis, I don't think we should touch it. The decision to proceed with concomitant aortic valve replacement in patients with moderate aortic stenosis, again, based on the natural history of the disease. When we look at the patients with moderate aortic stenosis, there are basically two groups that we see. There are patients who decrease the effective valve area anywhere from 0.1 to 0.3 centimeters squared per year. But about half of these patients that we follow up either with cardiac cath and during cardiac cath and with echocardiographic findings show that about half of these patients, there may be very little, if no progression over at least follow-up of about 3 to 9 years. But when we look at the rate of progression, as I said, it varies widely among patients. On average, we talk about the mean systolic pressure gradient change of about 3 to 7 millimeter mercury per year in accordance with the 0.1 centimeter squared change. But there are people who actually change their valve progression or stenosis gradient up to 15 to 19 millimeter mercury per year in some of these patients. And we don't really know why some patients do this. And obviously, as I said, I'm just going to reiterate that decrease in aortic valve area, on average rate of 0.1 centimeter squared that we see in the textbooks. But again, there are some patients with a little or no progression. And on the other hand, there are some patients who actually go faster rate of about 0.3 centimeters squared per year. And I guess those are the patients that we really need to worry about when we talk about it. We don't talk about it as much with the aortic jet velocity increase in the average of about 0.3 meters per second per year in these patients at the same time. Some patients with moderate aortic stenosis who undergo only CABG will progress to severe disease, as I alluded. And the valve replacement at this later time, again, is usually associated with the higher risk of mortality than initially combined surgery. That's our thoughts, or my thought, in a way. But as I said at the beginning, it's a cumulative mortality rather than we shouldn't be just looking at saying at the time of second surgery. There are two studies that actually combined and looked at it between Figel and Odell. They looked at 229 patients undergoing aortic valve replacement after prior CABG. So CABG first, and then looking at the redo surgery for aortic valve replacement. And these patients, they thought that their mortality rate was about 13% operative. And when you look at these patients after the initial post-op surgery, the post-op complications included worsening of the heart failure when they did not undergo aortic valve replacement, up to about 1/3 of the patient group, and the perioperative MI in about 10% of these patients at the initial time. And again, there are some other centers who have not noted any change or any increase in early risk with the combined surgery. This is a retrospective study of Cleveland Clinic that they did, and going through all the data, they probably have one of the nicest description. They looked at 207 patients who underwent coronary artery bypass grafting, either with mild aortic stenosis or moderate aortic stenosis on the pre-op or intra-op echocardiogram. And they identified moderate stenosis associated in 71% patients, that is about a quarter of these patients. And their mean transvalvular gradient they measured at the time of initial surgery was about 30 to 40, less than 40, and the valve area between 1 to 1.5 centimeters square. When they looked at this, they thought that the perioperative mortality was similar among 129 patients who underwent just CABG alone of 3.9%, or 78 patients who underwent the combined procedure. And again, their mortality was 3.8%, and they felt that they were about the same whether you combined it or just underwent single. When they looked at the 129 patients that actually only went coronary artery bypass grafting, they identified out of 126, 80% were mild aortic stenosis, and moderate aortic stenosis in about 18-20%. And among this 129 patients, 21 of them, about 16%, subsequently underwent aortic valve replacement at about mean of 6.2 years. And as we could have guessed, higher percentage, 30% of the patients who had initial moderate aortic stenosis underwent disc redo surgery compared to the mild aortic stenosis patients. When they actually re-looked at the 71 patients who initially had moderate aortic stenosis, the mortality at 6 years, the mean mortality, the combined surgical and aortic valve replacement and CABG was 42%, but when they underwent CABG alone in these 71 patients, that their mortality was much higher at 78%. And again, with mild aortic stenosis, there were no surgical benefit of the combined procedure. So I'm going to turn the page around the other way, because you can't just tell you how good it is. Dagenet wrote the paper on at the Annals on 2010's group of surgeons from Montreal, not too far away from Toronto, where I'm from. And they looked at the moderate aortic stenosis in patients undergoing coronary artery bypass grafting greater than 70 years. And their question was to replace or not to replace. Their patient characteristics were similar to a certain extent, but out of the 263 patients that they looked at, all greater than 7 years of age, CABG with moderate aortic stenosis, and out of those, 167 underwent CABG alone, and 96 underwent CABG plus aortic valve replacement. You have to remember, this is not a prospective study. They're looking at this, and the decisions to either undergo one way or the other is at the time of surgery, according to the patient. They said that the groups are comparable to major preoperative variables, but there was when you actually look at their data, higher maximal aortic valve gradient and the lower index valve area were documented in the patients undergoing coronary artery bypass plus aortic valve replacement group. And the number of distal grafts was significantly higher in the CABG alone group. They don't explain exactly why. I actually called him, but he couldn't tell me why. In patients who actually underwent CABG with aortic valve replacement combined procedure, obviously, as you could imagine, their combined cardiopulmonary bypass and cross-clamp time was much increased. And the increased comorbidity in these patients were seen, including TIA, CVA in patients, renal failure, mediastinitis, and reoperation for bleeding, all statistically significant. At the present time, the management of moderate aortic stenosis at the time of CABG is highly debated. Like Dr. Songwan said, we're there, we might as well do this, but I think it's slightly more complicated than that. And the problem, again, is even more complex for elderly patients owing to an increased operative risk with aging and the difficulty in assessing whether the patient will again outlive the natural history of the aortic valve disease at the time. And I believe one must consider patients' comorbidities in decision process to perform concomitant procedure, especially in elderly patients with moderate aortic stenosis. But there are a lot of aortic elderly patients who are actually superb, in superb health, that we do anything, even there at age 80. But then we really need to look at their comorbidities, whether they have an associated renal failure, their slightly dementia coming in, what their daily living is like, etc. The recent advancement in the transcatheter aortic valve replacement or implantation has certainly shown feasible in the setting of previous CABG. We started to do a lot of TAVIs, and so our decision, especially when the patients are iffy, as I said, that they're a little higher risk patients, our decision has been much helpful in shunning away. As far as the transcatheter technology, results are certainly encouraging, and with further technical refinement and longer follow-up, the transcatheter aortic valve implantation may become the preferred treatment modality for elderly patients with comorbidities requiring aortic valve replacement after previously undergoing initial coronary artery bypass. As we talked about at the very first talk about what happens to the centers who doesn't have a lot of money, who doesn't have a lot of technology, I think you have to go back to what we did before TAVI and say, do we really need to just leave these patients alone or carry on and then do both surgery at the time? And I think it all depends on the patient's clinical status at the time. The idea of a surgical CABG and aortic valve replacement still should be out there for all the surgeons, and not be discouraged that we're going to be looking just at the transcatheter technology at the end. Thank you so much. I guess I don't have any time for questions.
Thank you very much. Any burning question? Yes.
Nice talk, sir. Just regarding moderate aortic stenosis with coronary artery disease with low LVs, low EFs, low ejection fraction LVs, do you do a AVR plus CABG in those patients, or you just go for a CABG and leave the AVR later?
Well, it depends. If the patient is acutely having an acute coronary syndrome and they have an associated low ejection fraction because their whole status is poor, I tend to just do what I need to do to get out, and then we'll deal with it. And as I said, transcatheter technology is available for, at least for me, and so that may be something that may go on. But if the patient is elective and comes in and moderate aortic stenosis, we're kind of talking back and forth, but at the same time, ejection fraction is low, I'll go ahead and do it. I mean, you know that people with a severe aortic stenosis who's got a low ejection fraction, they actually do well with aortic valve replacement because now you open up the whole thing.
Yeah. So. The place where I come from, the whole procedure cost is borne by the patient. There is no insurance for any patient from the national side. So in these patients, we tend to do all things together if it is possible, and don't leave anything later. So in these patients with moderate aortic stenosis, if we ask any Indian surgeon, they will prefer to do a CABG plus aortic valve replacement, most probably a bioprosthetic valve, because a patient will not come to us second time to get operated or do a TAVI, because TAVI in India is still a big bomb of cash, which is not possible for almost 90% of the population of the country.
I agree with you, absolutely. I don't want second surgery. I don't think anybody here wants second surgery or second procedure. If the candidate is a good candidate, I think you should go ahead and get this done. But if the patient has a lot of comorbidities, that may actually, some of the papers, that if the comorbidity is enough that their hospitalization is prolonged, that their risk of perioperative problem becomes much higher, then we should shun away. But if all things are same, you are there, I think we should do it. The other thing with I find we do a lot of stentless valves too in our institute. So it shortens the surgical time, the ischemic time, cross-clamp time for us a lot. So we tend to go that way, especially in elderly. But Canada is still poor country. But regardless of that, I think as a surgeon, if I'm there with all the things equal, I would do CABG and aortic valve replacement in these patients without any questions, unless they're 85 and they won't outlive the valve or their problem. But I think that's what you should do, one-stop shopping.
Thank you.
Thank you.
Thank you very much, Dr. Moon. And thank everyone for attending this session. Let's have some coffee. Thank you very much.